Good morning, future histotechnology superheroes. We're about to embark on a thrilling journey into the microscopic world of myeloproliferative neoplasms, or MPNs, and myelodysplastic syndromes, MDS. This is your essential guide, your secret decoder ring, to understanding these complex clonal hematopoietic disorders right from the heart of where it all begins, the bone marrow. Your keen eye and meticulous technique are absolutely critical when it comes to conditions like MPNs and MDS. You're the master artisans who transform delicate tissue into diagnostic gold. So, grab your mental magnifying glasses, prepare for some serious cellular sleuthing, and let's embark on this adventure. Alright, team, let's kick things off by really understanding what we mean when we talk about myeloproliferative neoplasms, or MPNs. Imagine your bone marrow as a highly efficient, well-regulated factory, constantly churning out billions of new blood cells every single day. At its core, an MPN is a clonal hematopoietic stem cell disease. This means the disease originates from a single, abnormal stem cell that starts replicating itself and its abnormal offspring. The hallmark of these conditions is the expansion, excessive production, and overaccumulation of one or more myeloid cell lines. Genetic mutations in the hematopoietic stem cells are the root cause, essentially telling the cell, go forth and multiply, and don't stop. So, when you're looking at a slide from a patient suspected of having an MPN, you're seeing the downstream effects of a single, genetically altered stem cell. Let's move on to how the big wigs, the World Health Organization, classify these fascinating disorders. Now that we have a general idea of what MPNs are, essentially, our bone marrow's production line going a bit haywire, let's talk about how the experts, the World Health Organization, categorize these conditions. The WHO classification system for tumors of hematopoietic and lymphoid tissues is our go-to guide. For our purposes, the WHO has neatly divided these myeloproliferative neoplasms into four major categories. First up, chronic myelogenous leukemia, or CML, which is specifically noted as BCR-ABL1 positive. Next, polycythemia vera, or PV, where red blood cells are the main event. Then there's essential thrombocythemia, or ET, characterized by a significant increase in platelets. And finally, primary myelofibrosis, or PMF, where the bone marrow becomes fibrotic. Understanding these classifications is crucial because it guides diagnosis, prognosis, and treatment. Ready for the next chapter? Alright, let's peel back another layer and talk about the general pathogenesis of MPNs, essentially, how these conditions develop at a fundamental level. While each MPN has its unique flavor, there's a common thread. The core mechanism is the clonal expansion of hematopoietic stem cells. This leads directly to the excessive production and accumulation of mature myeloid cells. Because the mutated stem cell is biased towards producing certain types of mature myeloid cells, we see an overabundance of these cells. Ultimately, this clonal expansion and overproduction result in the disruption of normal hematopoiesis. The normal, healthy stem cells get crowded out, and the finely tuned balance of blood cell production is thrown off. Despite their individual characteristics, it's fascinating to note that these MPNs share common clinical features, laboratory findings, and pathogenetic similarities. Onward to the general lab findings. Alright, histotechs, let's talk about the big picture. What do these MPNs actually look like in a patient, and what are the general clues we gather from the lab? Many MPNs have an insidious onset, meaning they creep up slowly, often without dramatic symptoms at first. Patients might experience fatigue, unexplained weight loss, low-grade fever, or drenching night sweats. As the disease progresses, we might see splenomegaly or hepatomegaly. And here's a tricky part: despite having too many cells, patients can experience both thrombosis and bleeding. Now, let's shift to the general laboratory findings. On a complete blood count, the results will vary depending on the specific MPN. When you look at the peripheral blood smear, you're going to be looking for some telltale signs like immature cells, dysplastic features, and teardrop cells. Moving to the bone marrow, you'll typically find hypercellularity. Finally, the modern diagnosis of MPNs heavily relies on molecular and cytogenetic studies. With this overview in mind, let's dive into the specifics of each MPN, starting with the big one, chronic myelogenous leukemia. Alright, let's kick off our deep dive into the individual MPNs with perhaps the most well-known and historically significant of the bunch, chronic myelogenous leukemia, or CML. We just finished our overview of general MPN features, and CML is a prime example of how a specific genetic event drives a distinct disease. This isn't just any old leukemia, it's famous for its unique genetic signature. What truly sets CML apart is the Philadelphia chromosome, a specific translocation between chromosome 9 and chromosome 22. This translocation creates the BCR-ABL1 fusion gene, which produces an always-on tyrosine kinase that drives uncontrolled cell growth. Think of it like a cellular accelerator pedal stuck to the floor. For us histotechs, BCR-ABL1 positivity is the absolute diagnostic hallmark of CML. It's the definitive proof, even more so than morphology. This is why molecular testing has revolutionized CML diagnosis and treatment. So, when you hear CML, immediately think Philadelphia chromosome and BCR-ABL1. It's a match made in, well, not exactly heaven, but certainly in the diagnostic lab. This genetic signature is what makes CML so distinct from other MPNs. Let's move on to how this disease progresses through different phases. Now that we've met the star of our CML show, the Philadelphia chromosome, let's talk about how this disease actually presents and its rather dramatic progression. We just discussed the genetic driver, and now we'll see how that translates clinically. CML often has an insidious onset, meaning it's sneaky. Patients might be asymptomatic, with symptoms like fatigue or splenomegaly appearing later. But here's where CML gets really interesting. It typically progresses through 3 distinct phases, like a 3-act play. Act 1 is the chronic phase, where the disease is stable and manageable, with less than 10% blasts. This is where most patients are diagnosed. Act 2 is the accelerated phase, where things get challenging, with 10 to 19% blasts and worsening symptoms. The disease is becoming less responsive to treatment. Act 3, the blast phase or blast crisis, resembles acute leukemia, with 20% or more blasts and a poor prognosis. This is the most aggressive stage. Your observations on the peripheral blood smear and bone marrow biopsy provide critical clues that guide the clinical team in identifying these phases. Let's move on to the specific morphological features we look for in the peripheral blood during these phases. Alright, histotechs, let's get down to the nitty-gritty. What are we actually going to see when we look at a peripheral blood smear from a patient with CML, especially in that chronic phase? We just talked about the clinical phases, and now we'll see the cellular evidence. You're often going to be greeted by a veritable granulocytic gala, a party of white blood cells. The most striking feature is usually marked leukocytosis, often exceeding 100 times 10 to the power of 9 divided by L. It's a crowded field. Accompanying this is a prominent left shift, meaning you'll see a full spectrum of immature granulocytes, but with blasts typically less than 5%. Pay close attention to basophilia and eosinophilia. These are very common and often key indicators in CML. Thrombocytosis, an increased platelet count, is also very common. Your ability to accurately identify and quantify these cells is paramount for the initial diagnosis and for monitoring disease progression. Next, we'll venture into the bone marrow to see what's happening at the source. Alright, histotechs, we've seen the bustling activity in the peripheral blood, now let's go straight to the source, the bone marrow. We just covered the peripheral blood findings, and now we'll examine the factory floor itself. When you examine a bone marrow biopsy or aspirate from a CML patient, you're often going to encounter what I like to call a granulocytic gold rush. The most immediate observation will likely be hypercellularity, often 90 to 100% cellular. It's packed. Within this, you'll notice a distinct expansion of the granulocyte pool, dramatically skewing the myeloid, erythroid, MNE ratio to 10 to 1 or even 30 to 1. blasts should remain less than 5% in the chronic phase. Megakaryocytes can be normal to increased, but often appear immature or atypical. Understanding the bone marrow morphology in CML is absolutely essential for confirming the diagnosis and assessing disease burden. Next up, we'll talk about a classic lab test that helps us differentiate CML from other conditions, the leukocyte alkaline phosphatase, or LAP score. Alright, Histotex, let's talk about a classic, old-school, but still incredibly useful test in the diagnosis of myeloproliferative disorders, the leukocyte alkaline phosphatase, or LAP score. We just finished discussing the bone marrow morphology in CML, and this test provides a functional insight into those cells. This isn't a molecular test, but rather a cytochemical stain that gives us valuable information about the metabolic activity of neutrophils. LAP is an enzyme found in the secondary granules of mature neutrophils and bands, and its activity reflects their metabolic state. We score its activity from 0 to 4+ in 100 mature segmented neutrophils and bands, then sum those scores. The normal range for a LAP score is approximately 20 to 100. Deviations from this range can be incredibly informative in differentiating between various conditions that cause an increase in white blood cells. It's like taking the temperature of the neutrophil's internal engine. Next, we'll dive into how we interpret these scores, especially in the context of CML versus a leukemoid reaction. Now that we know how to calculate the LAP score, let's talk about what those numbers actually tell us. This is where the LAP score truly earns its stripes as a diagnostic tool, especially when we're trying to differentiate CML from other conditions that can cause a sky-high white blood cell count. A markedly decreased LAP score, typically less than 20, is a characteristic feature of untreated chronic myelogenous leukemia. This happens because the rapidly produced neutrophils in CML are often functionally immature, leading to low enzymatic activity. So, if you see a patient with significant leukocytosis and a very low LAP score, CML should be at the top of your differential diagnosis list. It's a powerful clue. On the flip side, high LAP scores, usually greater than 100, are most commonly found in leukemoid reactions. Here, the neutrophils are responding appropriately to a stimulus like infection, so they're functionally active and mature, hence their high LAP activity. This distinction is incredibly important for differential diagnosis. The LAP score helps us differentiate CML from other conditions causing leukocytosis. It's a simple, inexpensive test that provides a crucial piece of the puzzle. While molecular tests like BCR-ABL1 are definitive for CML, the LAP score can quickly point us in the right direction, especially in resource-limited settings or as an initial screening tool. Next, we'll put this knowledge to the test and compare CML directly with leukemoid reactions. Alright, Histotex, this is where the rubber meets the road, and your diagnostic acumen truly shines. Both CML and a leukemoid reaction can present with a strikingly similar picture, a very high white blood cell count and a pronounced left shift on the peripheral blood smear. Imagine a pathologist looking at a slide, seeing all those immature granulocytes, and thinking, is this CML, or is the patient just fighting off a really nasty infection? This is a critical distinction, because the prognosis and treatment for these two conditions are vastly different. So, how do we, as the cellular detectives, help differentiate CML from a leukemoid reaction? We rely on a combination of morphological clues, the LAP score we just discussed, and ultimately, molecular diagnostics. While both have a left shift, CML often shows a more complete spectrum of immature granulocytes, including myelocytes and metamyelocytes, in higher proportions. Leukemoid reactions tend to have a more orderly maturation, with fewer very immature forms. The presence of basophilia and eosinophilia is a huge red flag for CML. These are typically absent or minimal in a reactive process. Then there's the platelet count. In CML, you'll often see thrombocytosis, sometimes with abnormal platelet morphology. In a leukemoid reaction, platelets are usually normal or only slightly increased. And of course, our good friend, the LAP score. This is one of the most powerful discriminators. A markedly decreased lap score is highly suggestive of CML, while a markedly increased lap score points towards a leukemoid reaction. It's like a cellular litmus test. Finally, the definitive test, the BCR-ABL1 gene. It's present in CML and absent in a leukemoid reaction. This molecular test is the gold standard for confirming CML. So, while your morphological observations and lap score can strongly suggest CML, the molecular confirmation is what seals the deal. Understanding these differences is not just academic, it directly impacts patient care. Your careful observation and accurate reporting are crucial in guiding the clinical team to the correct diagnosis and ensuring the patient receives the appropriate treatment. With that, let's transition to our next MPN, polycythemia vera. Alright, histotechs, let's shift our focus from the granulocytic frenzy of CML to another fascinating MPN, polycythemia vera, or PV. If CML was about too many white blood cells, PV is primarily about a red cell rush and absolute erythrocytosis. This means patients with PV have an abnormally high number of red blood cells, leading to increased hemoglobin and hematocrit levels. It's like the red blood cell production line in our bone marrow factory has gone into hyperdrive. While the red cells definitely steal the show, it's important to remember that PV is still a myeloproliferative neoplasm. This means that while erythrocytosis is the most prominent feature, there's often a proliferation of all three myeloid cell lines in the bone marrow, a phenomenon we call panmyelosis. So, you might also see increased granulocytes and megakaryocytes, but the red cell increase is the defining characteristic. Now, what's the genetic culprit behind this red cell overproduction? In PV, the vast majority of cases, over 95% to be precise, are associated with a specific mutation in the JAK2 gene, the JAK2V617F mutation. This mutation is a game changer in the diagnosis of PV. The JAK2 gene encodes a protein called Janus kinase 2, which is a crucial signaling molecule involved in regulating blood cell production. The V617F mutation makes this protein constitutively active, meaning it's always on, constantly signaling the hematopoietic stem cells to produce more blood cells, particularly red blood cells, even when the body doesn't need them. It's like the accelerator pedal is stuck to the floor. For the remaining PV cases where the V617F mutation isn't found, most are attributed to JAK2 exon 12 mutations. So, essentially, if you suspect PV, you're almost certainly looking for a JAK2 mutation. This makes molecular testing for JAK2 mutations a cornerstone of PV diagnosis. One of the most critical aspects of PV is that this red cell production is erythropoietin, EPO, independent. Normally, red blood cell production is tightly regulated by EPO, a hormone produced by the kidneys. When oxygen levels are low, EPO increases, stimulating red cell production. In PV, however, the mutated JAK2 pathway bypasses this normal regulatory mechanism. The bone marrow just keeps churning out red cells, regardless of how much EPO is present. In fact, EPO levels in PV patients are often low or normal because the body is trying to shut down the overproduction, but the mutated cells aren't listening. This is a key differentiator from other causes of erythrocytosis, which we'll discuss shortly. So, remember, PV equals red cell excess, and JAK2 is the primary driver, making those cells march to the beat of their own drum, ignoring the body's signals. Let's move on to the pathogenesis of this red cell rebellion. Alright, histotechs, let's delve a bit deeper into the how of polycythemia vera, its pathogenesis. We've established that PV is a red cell party gone wild, driven primarily by the JAK2 mutation. At its heart, PV is a clonal disorder, starting with one mutated hematopoietic stem cell that gains a growth advantage. The key mechanism is the constitutive activation of the JAK-STAT pathway. The mutated JAK2 protein is permanently on, constantly signaling erythroid precursors to proliferate and mature, even without external stimulation. This leads directly to erythropoietin, EPO, independence. The erythroid precursors don't need EPO to grow and mature, ignoring the body's normal regulatory signals. Because the body is smart, it tries to compensate for this red cell overload, resulting in suppressed endogenous EPO levels. All this uncontrolled proliferation ultimately leads to a significantly increased red cell mass. This makes the blood thicker, increasing its viscosity, and dramatically raises the patient's risk of thrombosis. Next, let's look at what this looks like in the peripheral blood. Alright, histotechs, let's bring it back to the microscope. What are we going to see when we examine a peripheral blood smear from a patient with polycythemia vera? If CML was a granulocytic gala, PV is definitely a crowded highway of red blood cells. The most obvious feature is absolute erythrocytosis, meaning a significantly increased red blood cell count, reflected in elevated hemoglobin and hematocrit levels. The smear will often appear very crowded or thick. Regarding RBC morphology, initially, the red blood cells are typically normochromic and normocytic. However, due to chronic overproduction, patients can develop iron deficiency, leading to hypochromic and microcytic RBCs. While PV is primarily an erythroid disorder, you might also see leukocytosis, specifically a neutrophilia, and sometimes eosinophilia or basophilia. Thrombocytosis, an increased platelet count, is also common. Your role here is to meticulously document the degree of erythrocytosis, note any changes in red cell morphology, and accurately assess the white blood cell and platelet populations. Next, we'll take a peek into the bone marrow in PV. Alright, histotechs, we've seen the crowded peripheral blood in polycythemia vera. Now let's go deeper into the bone marrow, the heart of the matter. When you examine a bone marrow biopsy or aspirate from a PV patient, you're going to see a bustling scene, a true panmyelotic party. The bone marrow in PV is typically hypercellular, reflecting proliferation in all three myeloid cell lines. Interestingly, the myeloid-erythroid (ME) ratio in PV is usually normal to decreased, because the erythroid hyperplasia is so prominent. You'll typically find megakaryocytes increased in number, often enlarged, and they may exhibit lobulated nuclei. One of the most telling features is that iron stores are decreased to absent due to increased red cell production. Finally, reticulin fibrosis may develop over time in PV, especially in later stages. Understanding these bone marrow features is crucial for confirming a diagnosis of PV and for monitoring its progression. Next, let's quickly touch upon conditions that can mimic PV, secondary and relative polycythemia, because not all red cell increases are created equal. Alright, histotechs, we've just talked about polycythemia vera, where the red cell production line goes rogue due to a genetic mutation. But it's crucial to understand that not all increases in red blood cells are PV. This is where secondary polycythemia comes into play. Unlike PV, secondary polycythemia is characterized by increased red blood cell production due to an appropriate increase in erythropoietin, EPO. This means the body is producing more EPO because it genuinely needs more red blood cells, usually to compensate for a lack of oxygen. Common causes include hypoxia from chronic lung disease, high altitude, or heavy smoking. Certain tumors or kidney conditions can also cause inappropriate EPO production. From a laboratory perspective, you'll find elevated hemoglobin and hematocrit, but a key differentiator is that the white blood cell and platelet counts are typically normal. And the absolute clincher? Elevated EPO levels. This is the opposite of PV, where EPO is low or normal. Next, we'll quickly cover relative polycythemia, which is another imposter. Alright, histotechs, last but not least in our polycythemia discussion, let's quickly cover relative polycythemia. This one is a bit of a trickster, because while the patient's hemoglobin and hematocrit might appear elevated, there isn't actually an increase in the total red blood cell mass. It's all about the fluid. Relative polycythemia is defined as an apparent increase in red blood cell count due to a decrease in plasma volume. The most frequent culprit is dehydration, which can be due to severe vomiting, prolonged diarrhea, or inadequate fluid intake. From a laboratory findings perspective, you'll see elevated hemoglobin and hematocrit, but the actual red cell mass is normal. Crucially, the white blood cell and platelet counts will be normal, and the bone marrow will also appear normal. And, importantly, EPO levels will be normal. The differentiation from true polycythemias is often quite straightforward, as relative polycythemia is easily resolved by rehydration. With that, we've covered the nuances of polycythemia vera and its lookalikes. Next up, we're going to explore essential thrombocythemia, where the platelets take center stage. Alright, histotechs, we've talked about too many white cells in CML and too many red cells in PV. Now, let's turn our attention to the third major player in the MPN lineup, essential thrombocythemia, or ET. As the name suggests, thrombos refers to platelets, and essential here means it's a primary bone marrow disorder, not secondary to something else. So, ET is a myeloproliferative neoplasm characterized by marked, sustained thrombocytosis. We're talking about platelet counts that are persistently and significantly elevated, often exceeding 450 times 10 to the power of 9 divided by L, and sometimes reaching astronomical numbers. The primary affected cell line in ET is, you guessed it, the megakaryocytes and their progeny, the platelets. The bone marrow's megakaryocyte production line has gone into overdrive, churning out an excessive number of platelets. It's like the platelet factory has decided to host a never-ending party, and everyone's invited. Now, what are the key mutations driving this platelet party? Just like PV, ET is also frequently associated with the JAK2V617F mutation, found in about 50 to 60% of ET patients. This highlights the shared molecular pathogenesis among some MPNs. However, ET also has its own unique set of genetic signatures. Another significant player is CALR, or calreticulin, mutations, which are found in approximately 20 to 25% of ET patients. These mutations are particularly interesting because they are mutually exclusive with JAK2 mutations, meaning a patient usually has one or the other, but not both. CALR mutations are often associated with a more favorable prognosis. Then we have MPL, or myeloproliferative leukemia virus oncogene, mutations, which account for about 5 to 10% of ET cases. These mutations also lead to constitutive activation of signaling pathways that promote megakaryocyte proliferation. Finally, about 10 to 15% of ET patients are considered triple-negative ET. This means they lack all three of these common mutations, JAK2, CALR, and MPL. While they still have ET, their underlying genetic drivers are yet to be fully elucidated, making their diagnosis a bit more challenging and often requiring exclusion of other MPNs. Regardless of the specific mutation, ET is fundamentally a clonal disorder, arising from a mutated hematopoietic stem cell that gives rise to this excessive and often dysfunctional platelet production. Understanding these genetic drivers is crucial for accurate diagnosis, prognosis, and increasingly, for guiding targeted therapies. So, when you're thinking ET, think platelets, and think JAK2, CALR, and MPL. Let's move on to the clinical features and what these patients actually experience. Alright, histotechs, we've established that essential thrombocythemia is all about an excess of platelets. But what does this actually mean for the patient? What are the clinical features they experience? Interestingly, many patients with ET are often asymptomatic. They might be going about their daily lives, feeling perfectly fine, and their ET is only discovered incidentally during a routine blood test that reveals a persistently elevated platelet count, often greater than or equal to 450 x 10^9/L. It's like finding out you've won the lottery, but instead of money, it's platelets. However, the high platelet count can lead to a rather paradoxical set of complications. You'd think with so many platelets, clotting would be the only issue, right? Well, not quite. Patients with ET are indeed at an increased risk of thrombosis, meaning blood clots. These can occur in both arteries and veins, leading to serious events like strokes, heart attacks, or deep vein thromboses. This risk is due to the sheer number of platelets, which increases blood viscosity, and also due to the platelets themselves often being dysfunctional. They're not just numerous, they're often not working correctly. And here's the paradox: despite having an abundance of platelets, patients with ET can also experience bleeding complications. This is because, as I just mentioned, the platelets are often dysfunctional. They might be numerous, but they're not very good at forming a proper clot when needed. So, you can have a patient with a platelet count of over 1 million, yet they might be prone to easy bruising, nosebleeds, or gastrointestinal bleeding. It's a classic case of quantity over quality, and it makes managing these patients quite challenging. Beyond these major complications, patients might experience other, more subtle symptoms. These include microvascular disturbances, which are problems in the tiny blood vessels. This can manifest as erythromelalgia, a burning pain in the hands and feet, often relieved by aspirin. They might also experience transient ischemic attacks, TIAs, which are mini strokes, or general symptoms like headache, dizziness, and fatigue. These are often related to impaired blood flow due to the increased platelet count. Finally, mild splenomegaly, or an enlarged spleen, may also be present in some ET patients. This is less common and usually less pronounced than in other MPNs like CML or PMF, but it's something to look out for. So, when you're thinking ET, remember the high platelet count, but also the perplexing balance between clotting and bleeding, and the potential for microvascular issues. It's a disease that keeps clinicians and histotechs on their toes. Next, let's examine what these platelets look like on the peripheral blood smear. Alright, histotechs, let's get our eyes on the prize, or rather, the platelets, in essential thrombocythemia. When you're looking at a peripheral blood smear from an ET patient, the first thing that's going to jump out at you is the sheer abundance of platelets. It's a marked thrombocytosis, and I mean marked. You'll see fields absolutely teeming with platelets, often forming large aggregates. It's like a platelet parade, and everyone's invited. Beyond just the numbers, you'll also notice a significant variation in platelet size. You might see some tiny platelets, but more strikingly, you'll encounter giant platelets. These aren't just a little bigger, they can be as large as, or even larger than, red blood cells. These giant forms are a direct result of the abnormal megakaryopoiesis in the bone marrow. And it's not just about size, the abnormal platelet morphology is also a key feature. You might observe platelets with hypergranulation, fewer granules than normal, or even agranulation, a complete absence of granules, making them appear pale or empty. Some platelets might have bizarre, irregular shapes, reflecting the dysplastic changes occurring in their parent megakaryocytes. These morphological abnormalities contribute to the dysfunctional nature of the platelets, explaining why patients can experience bleeding despite high counts. What about the other cell lines? The red blood cells are typically normocytic and normochromic. They usually look quite normal, just trying to navigate through the sea of platelets. And the white blood cells are generally normal to slightly increased, with normal maturation and distribution. You won't typically see the dramatic left shift or prominent basophilia/eosinophilia that characterizes CML. So, while the overall cellularity might be a bit higher, the focus here is definitely on the platelets. Your role in meticulously observing and documenting these platelet features, their number, size variation, and any morphological abnormalities, is crucial for the initial diagnosis and for monitoring disease progression. These observations are crucial for the pathologist to confirm the diagnosis of ET and to monitor the patient's response to treatment. It's all about seeing the big picture, even when it's crowded. Next, let's head into the bone marrow to see where these wild platelets are coming from. Alright, histotechs, we've seen the platelet party in the peripheral blood, now let's go to the source of all that thrombocytic activity, the bone marrow in essential thrombocythemia. When you examine a bone marrow biopsy or aspirate from an ET patient, you're going to find that the megakaryocytes are definitely in the spotlight. The bone marrow will typically show hypercellularity, primarily driven by the increased megakaryopoiesis. It's a busy place, but the megakaryocytes are the undeniable stars of the show. You'll find them markedly increased in number, often forming loose to dense clusters. Instead of being scattered individually, they tend to huddle together, which is a characteristic feature. And it's not just their numbers, their morphology is also quite distinctive. These megakaryocytes are typically large and mature, with abundant cytoplasm. What's particularly striking are their nuclei. They are often deeply lobulated or even hyperlobulated. Imagine a nucleus that looks like it's been folded in on itself multiple times, creating many distinct lobes. This abnormal nuclear morphology is a key indicator of dysplastic megakaryopoiesis in ET. While the megakaryocytes are the main event, you might also observe mild to moderate granulocytic and erythroid hyperplasia. This means there might be a slight increase in granulocyte and red blood cell precursors, but it's usually not as prominent or as dramatic as the megakaryocytic proliferation. The M/E ratio is typically normal or slightly increased, but the overall picture is dominated by the megakaryocytes. One crucial feature to note, especially when differentiating ET from primary myelofibrosis, is the presence or absence of reticulin fibrosis. In ET, fibrosis is typically absent or minimal. If you see significant fibrosis, it should make you reconsider the diagnosis and think about PMF or a post-ET myelofibrotic transformation. So, your careful assessment of the reticulin stain is vital here. Your ability to identify these characteristic megakaryocytic changes, their increased numbers, clustering, large size, and hyperlobulated nuclei, is essential for confirming the diagnosis of ET. It's a beautiful example of how specific morphological features in the bone marrow directly correlate with the clinical picture. Next, let's talk about how we differentiate ET from another condition that causes high platelets, reactive thrombocytosis. Alright, histotex, just like we had to differentiate CML from a leukemoid reaction, it's equally crucial to distinguish essential thrombocythemia, ET, from reactive thrombocytosis. Both conditions present with an elevated platelet count, but their underlying causes, clinical implications, and management are vastly different. Reactive thrombocytosis is far more common, so knowing how to tell them apart is a fundamental skill. Reactive thrombocytosis is, as the name implies, an increase in platelet count that is secondary to another underlying condition. It's the bone marrow responding appropriately to a stimulus, much like a leukemoid reaction. Common causes include acute or chronic infections, inflammatory conditions like rheumatoid arthritis or inflammatory bowel disease, iron deficiency anemia, trauma, surgery, or even other malignancies. In these cases, the body needs more platelets for various reasons, and the bone marrow delivers. So, how do we differentiate between the two? Let's look at the key features, and again, a comparison table is your best friend here. While both can have high platelet counts, in ET, the counts are often much higher and persistently elevated, frequently exceeding 1,000 times 10 to the power of 9 divided by L. In reactive thrombocytosis, while elevated, the counts rarely reach such extreme levels and tend to normalize once the underlying cause is treated. Crucially, the platelet function is often abnormal in ET, leading to that paradoxical bleeding or clotting, whereas in reactive thrombocytosis, the platelets are generally functionally normal. From a morphological perspective, the megakaryocytes in the bone marrow are dysplastic in ET. Remember those large, hyperlobulated, clustered forms? In reactive thrombocytosis, the megakaryocytes are typically normal. And of course, the molecular tests are definitive. The presence of JAK2, CLR, or MPL mutations points strongly to ET, while these mutations are absent in reactive thrombocytosis. This is why molecular testing has become so indispensable. Finally, the underlying cause. ET is a primary clonal bone marrow disorder, meaning the problem originates in the stem cell itself. Reactive thrombocytosis is a secondary response to another condition. So, if you can identify and treat an underlying infection or inflammation, and the platelet count normalizes, you're looking at reactive thrombocytosis. Your role in carefully evaluating the peripheral blood smear, noting platelet morphology and count, and understanding the clinical context is paramount in guiding the diagnostic process. It's about putting all the pieces of the puzzle together. With that, we've covered ET. Now, let's move on to primary myelofibrosis, which is quite a different beast. Alright, histotechs, we've just wrapped up our discussion on essential thrombocythemia, where the platelets were the stars of the show. Now, let's shift gears to the last of our four major MPNs, primary myelofibrosis, or PMF. If CML was about granulocytes, PV about red cells, and ET about platelets, then PMF is primarily characterized by something else entirely, bone marrow fibrosis. This is a condition where the normal, healthy bone marrow is progressively replaced by scar tissue, leading to a host of problems. It's like the factory floor getting clogged up with concrete, making it impossible for the workers to do their job properly. PMF is a myeloproliferative neoplasm that, in addition to marrow fibrosis, is also characterized by extramedullary hematopoiesis, blood cell production happening outside the bone marrow, often in the spleen and liver, and a distinctive leukoerythroblastic peripheral blood picture. We'll dive into what that means shortly. Let's talk about the pathogenesis. Like the other MPNs, PMF starts with the clonal proliferation of abnormal hematopoietic stem cells. These mutated stem cells aren't just producing too many cells, they're also releasing a variety of cytokines and growth factors, such as transforming growth factor beta, TGF-beta, and platelet-derived growth factor, PDGF. These cytokines act as powerful signals that stimulate the fibroblasts, which are the cells responsible for producing connective tissue within the bone marrow. It's like the rogue stem cells are sending out memos telling the fibroblasts to go wild. This fibroblast stimulation leads to the excessive deposition of collagen and reticulin fibers in the bone marrow. Instead of a nice, open space for blood cell production, the marrow becomes dense and scarred. This is the fibrosis we see. Your reticulin and trichrome stains on bone marrow biopsies are absolutely critical for visualizing and grading this fibrosis. Similar to PV and ET, PMF is also associated with specific key mutations. The JAK2V617F mutation is found in about 50 to 60% of PMF patients, CLR mutations in about 20 to 30%, and MPL mutations in about 5 to 10%. Again, these mutations are generally mutually exclusive. About 10 to 15% of PMF cases are triple negative, lacking these common mutations. The consequences of this fibrosis are severe. The normal hematopoietic environment is destroyed, leading to impaired hematopoiesis. This results in cytopenias, a decrease in mature blood cells, and forces the body to try and produce blood cells elsewhere, leading to that extramedullary hematopoiesis we mentioned. So, the spleen and liver become enlarged as they try to take over the bone marrow's job. Understanding this scarring process is key to understanding the clinical and morphological features of PMF. Next, let's look at the two stages of PMF. Alright, histotechs, primary myelofibrosis isn't just one static condition, it often progresses through distinct stages. The first stage, and one that can be particularly tricky to diagnose, is the prefibrotic stage. This is the early phase of PMF, and it's often overlooked or even misdiagnosed, most commonly as essential thrombocythemia, because the hallmark fibrosis isn't yet prominent. It's the quiet before the storm, so to speak. In the bone marrow during the prefibrotic stage, you'll typically find hypercellularity. The marrow is still busy, but the key differentiating factor from the later fibrotic stage is that there's minimal reticulin fibrosis initially. This means that on a reticulin stain, you won't see the dense, widespread network of fibers that characterizes advanced PMF. This is why a careful assessment of the reticulin stain is so critical. What you will see prominently are the megakaryocytes. They are increased in number, often appearing atypical, large, and frequently clustered. Sound familiar? This is why it can be confused with ET, as these megakaryocytic features are shared. However, in prefibrotic PMF, the megakaryocytes often have more bizarre and pleomorphic nuclei compared to ET, and their clustering can be more pronounced. Granulocytes are also typically increased, and you might see some immature forms, contributing to a mild leukocytosis. The bone marrow is trying to compensate, but the underlying dysregulation is already at play. In the peripheral blood, patients in the prefibrotic stage may present with thrombocytosis or leukocytosis. Anemia might also be present, but it's usually not as severe as in the later fibrotic stage. The absence of significant fibrosis on the reticulin stain is the distinguishing feature that helps us identify this early phase of PMF. It requires a very keen eye and a high index of suspicion to catch PMF in this prefibrotic stage, as the overt signs of fibrosis are not yet present. Your meticulous attention to megakaryocyte morphology and the reticulin stain is paramount here. It's a subtle but crucial diagnosis to make, as early identification can impact patient management. Next, we'll move on to the more overt and often dramatic fibrotic stage. Alright, histotex, if the prefibrotic stage of PMF was the quiet before the storm, then the fibrotic stage is definitely the storm itself. This is the advanced stage of primary myelofibrosis, and it's characterized by extensive bone marrow fibrosis. This is where the marrow truly becomes a scarred, inhospitable environment for normal blood cell production. One of the most frustrating, yet diagnostically significant, experiences for a clinician performing a bone marrow aspiration in this stage is that it often results in a dry tap. Imagine trying to aspirate liquid from a sponge that's been completely filled with concrete. You're just not going to get much. This dry tap is a strong indicator of significant marrow fibrosis and should immediately raise suspicion for PMF. When you finally get a bone marrow biopsy, it will unequivocally show marked fibrosis. The normal hematopoietic tissue is largely replaced by dense collagen and reticulin fibers. Your reticulin and trichrome stains will light up like a Christmas tree, showing a dense, interwoven network of fibers that has essentially choked out the blood-forming cells. It's a dramatic and unmistakable picture. Amidst this fibrotic wasteland, you might still find some pockets of activity. These are often referred to as hematopoietic islands. These are small clusters of blood-forming cells trying their best to survive and produce blood cells in a very challenging environment. You'll also frequently see clumped megakaryocytes, sometimes with atypical morphology, scattered throughout the fibrotic marrow. These megakaryocytes are believed to be the primary drivers of the fibrosis, releasing those cytokines that stimulate collagen deposition. The functional consequence of this extensive fibrosis is progressive cytopenias. As the marrow becomes more and more scarred, its ability to produce red cells, white cells, and platelets diminishes. This leads to anemia, leukopenia, and thrombocytopenia, which contribute to many of the patient's symptoms. The body tries to compensate for this by initiating extramedullary hematopoiesis, where blood cell production shifts to organs like the spleen and liver, leading to their enlargement. It's a desperate attempt by the body to keep up with blood cell demand when its primary factory is failing. Your role in identifying and grading this fibrosis, along with noting the presence of atypical megakaryocytes and the overall cellularity, is paramount for diagnosing PMF in its fibrotic stage. Next, let's look at the distinctive peripheral blood picture that often accompanies this fibrotic marrow. Alright, histotex, we've talked about the scarred bone marrow in the fibrotic stage of PMF. Now, let's see how that translates to the peripheral blood. One of the most characteristic and diagnostically significant findings in PMF is what we call the leukoerythroblastic picture. It's like a symphony of immature cells that shouldn't normally be circulating in the peripheral blood. So, what exactly is a leukoerythroblastic picture? It's defined by the simultaneous presence of immature granulocytes, we're talking myelocytes, metamyelocytes, and even promyelocytes, and nucleated red blood cells, NRBCs, in the peripheral blood. Normally, these cells are confined to the bone marrow, diligently maturing before they're released into circulation. Their appearance in the peripheral blood is a clear sign that something is seriously amiss in the bone marrow. This leukoerythroblastic picture is often accompanied by other findings. You'll almost certainly see anemia, as the fibrotic marrow struggles to produce enough red blood cells. Your ability to recognize this combination of immature granulocytes and nucleated red blood cells on a peripheral blood smear is a crucial diagnostic skill. Let's zoom in on those fascinating teardrop cells next. Alright, histotechs, let's talk about some of the most iconic and diagnostically significant red blood cell morphologies you'll encounter in primary myelofibrosis, the teardrop cells, also known as dacryocytes and elliptocytes. These aren't just pretty shapes, they tell a powerful story about what's happening inside the patient's bone marrow. Teardrop cells are exactly what they sound like, red blood cells with a characteristic teardrop or pear shape. Their formation is believed to occur when red blood cells are forced to squeeze through the fibrotic, constricted bone marrow. The diagnostic significance of teardrop cells is immense. While they can be seen in other conditions with marrow infiltration or fibrosis, their presence in conjunction with a leukoerythroblastic picture is highly characteristic of PMF. In addition to teardrop cells, you'll also commonly observe elliptocytes. These are oval-shaped red blood cells, and while not as specific as teardrop cells for PMF, their presence contributes to the overall picture of abnormal erythropoiesis. Your ability to accurately identify and quantify these abnormal red cell morphologies is crucial. Next, let's talk about another key feature of PMF, extramedullary hematopoiesis. Alright, histotechs, we've discussed how the bone marrow in primary myelofibrosis becomes scarred and unable to do its job. But the body is incredibly resilient and resourceful, and it has a backup plan. When the primary hematopoietic factory, the bone marrow, fails, it initiates extramedullary hematopoiesis. Extramedullary hematopoiesis is simply defined as blood cell formation occurring outside the bone marrow. The primary sites for this extramedullary hematopoiesis are typically the spleen and liver. These organs were active sites of blood cell production during fetal development, and they can be reactivated in times of severe bone marrow stress. This is why splenomegaly, often massive, and hepatomegaly, enlarged liver, are such common clinical manifestations in PMF patients. The cause in PMF is directly linked to the extensive fibrosis. The fibrotic bone marrow can no longer effectively produce blood cells, leading to cytopenias. From our perspective as histotechs, extramedullary hematopoiesis has a direct consequence on what we see in the peripheral blood. It contributes significantly to the leukoerythroblastic picture. With that, we conclude our deep dive into MPNs. Next, we'll transition to myelodysplastic syndromes, which present a different, but equally fascinating, set of challenges. Alright, histotechs, we've just navigated the world of myeloproliferative neoplasms, where the problem was generally too much production. Now, let's shift gears and dive into the equally complex, and often more perplexing, realm of myelodysplastic syndromes, or MDS. If MPNs were about the bone marrow factory going into overdrive, MDS is about the factory having a serious quality control problem. At its core, MDS represents a group of acquired clonal hematological disorders. Just like MPNs, they originate from a single, mutated hematopoietic stem cell. But instead of just overproducing, this mutated stem cell produces cells that are defective, leading to a cascade of issues. The hallmarks of MDS are ineffective hematopoiesis, progressive cytopenias, and dysplasia. Ineffective hematopoiesis means that even though the bone marrow might be trying its best to make blood cells, the cells it produces are often abnormal and die prematurely, either in the marrow itself or shortly after being released into the peripheral blood. It's like the factory is producing a lot of products, but most of them are faulty and get discarded before they can even reach the market. This leads to progressive cytopenias, a fancy way of saying a decrease in one or more types of mature blood cells, red cells, white cells, or platelets, in the peripheral blood. So, despite a busy marrow, the patient ends up anemic, neutropenic, or thrombocytopenic. And the key visual clue for us? Dysplasia. This refers to abnormal maturation and morphology in the peripheral blood and bone marrow. These cells just don't look right. They might have odd shapes, abnormal granulation, or bizarre nuclear features. Your keen eye for these dysplastic changes is absolutely critical in diagnosing MDS. What's particularly interesting, and sometimes confusing, is that the bone marrow in MDS can be normocellular or even hypercellular. You might look at a biopsy and think, wow, this marrow is packed with cells. But despite this cellularity, the production is ineffective. It's a busy factory, but it's not producing functional goods. This is a key differentiator from conditions like aplastic anemia, where the marrow is hypocellular. Another significant aspect of MDS is the increased risk of transformation to acute myeloid leukemia, AML. In some cases, MDS can progress, and the number of blasts, very immature blood cells, in the bone marrow and peripheral blood increases, eventually crossing the threshold for AML. So, MDS can be seen as a pre-leukemic condition in many patients. Finally, MDS is incredibly heterogeneous. There's a wide range of presentations, from very indolent forms that might remain stable for years, to aggressive forms that rapidly transform into AML. This variability makes diagnosis and prognosis challenging, and it's why a detailed morphological assessment, combined with cytogenetic and molecular studies, is so important. So, get ready to sharpen your observational skills, because in MDS, every abnormal cell tells a story. Next, let's delve into the very beginning of the MDS story, its cell of origin. Alright, histotechs, let's delve into the very beginning of the MDS story, its cell of origin. Our understanding has evolved, and we now know that MDS actually originates from phenotypically normal hematopoietic stem cells that acquire somatic mutations. These are the foundational cells in the bone marrow, and a mutation in one of them can set the stage for MDS. This leads us to a fascinating and relatively new concept called clonal hematopoiesis of indeterminate potential, or CHIP. Imagine a healthy individual, going about their life, with no signs of any blood disorder. However, if we were to look closely at their hematopoietic stem cells, we might find that some of them have acquired somatic mutations, and these mutated cells have undergone a clonal expansion. This is CHIP, clonal hematopoiesis without any overt hematologic disorder. It's like having a few rogue workers in the factory, but they haven't caused any major problems yet. So, if someone has CHIP, does that mean they'll definitely get MDS? Not necessarily. The progression to MDS is a complex dance involving additional somatic mutations, epigenetic modifications, and the bone marrow microenvironment. It's not just one mutation, it's often a series of hits or changes that push the system over the edge from a benign clonal expansion to a full-blown myelodysplastic syndrome. CHIP is also an age-related phenomenon. It becomes more common as people get older. This highlights that while these mutations are present, they don't always lead to disease. Understanding CHIP is important because it represents a precursor state for many hematologic disorders, including MDS. Your role in recognizing the morphological signs of MDS is critical in identifying when this precursor state has crossed the line into overt disease. Next, let's explore the various etiologies of MDS, how these mutations come about. Alright, histotechs, we've talked about the cell of origin for MDS being a mutated hematopoietic stem cell. Now, let's explore how these mutations arise, the etiology of MDS. It's not a one-size-fits-all answer, there are several paths that can lead to the development of myelodysplastic syndromes. The most common category is de novo MDS, also known as primary MDS. In these cases, the mutations arise spontaneously, without any identifiable external cause. It's often considered a disease of aging, as the cumulative effect of cellular divisions and environmental exposures over a lifetime can lead to random genetic errors. This accounts for the majority of MDS cases. A particularly important category, especially in modern medicine, is therapy-related MDS, or TMDS. This develops in patients who have previously received chemotherapy and/or radiotherapy for a prior malignancy. While these treatments are life-saving for the primary cancer, they can, unfortunately, induce genetic damage in hematopoietic stem cells, leading to TMDS. This form of MDS is often more aggressive and tends to evolve quickly into acute myeloid leukemia. The median onset is typically 4 to 7 years after the initial cancer therapy, but it can vary depending on the agents used. This highlights the delicate balance in cancer treatment, curing one disease while potentially increasing the risk for another. Then there's secondary MDS, which arises from exposure to certain chemicals or radiation, but not as a result of therapeutic interventions. Classic examples include prolonged exposure to industrial chemicals like benzene, or accidental exposure to high levels of radiation. These environmental factors can directly damage DNA in hematopoietic stem cells, leading to dysplastic changes. Finally, we have inherited MDS. This is a less common but important category, associated with germline mutations in patients with inherited bone marrow failure syndromes. Conditions like Fanconi anemia, Diamond-Blackfan anemia, and Schwachman-Diamond syndrome are examples where patients have a genetic predisposition to developing MDS, often at a younger age. These patients are born with a genetic vulnerability that makes their hematopoietic stem cells more susceptible to acquiring additional mutations that lead to MDS. Understanding these different etiologies is crucial because it helps us understand the patient's history and can sometimes influence prognosis and treatment decisions. Your role in preparing the bone marrow and peripheral blood samples allows the pathologists and clinicians to piece together this complex origin story. Next, let's talk about a fascinating cellular process that goes awry in MDS, apoptosis. Alright, histotechs, we've just explored the various ways MDS can originate, from spontaneous mutations to therapy-related causes. Now, let's talk about a fundamental cellular process that plays a paradoxical and crucial role in myelodysplastic syndromes, apoptosis, or programmed cell death. Apoptosis is a beautifully orchestrated, normal process that our bodies use to remove old, damaged, or unnecessary cells in a controlled manner. It's essential for maintaining tissue homeostasis and preventing uncontrolled cell growth. Think of it as the body's efficient recycling and cleanup crew. In early MDS, we see a fascinating and somewhat counterintuitive phenomenon: there's increased apoptosis in the bone marrow. Even though the bone marrow might be hypercellular, many of the hematopoietic precursors are defective and undergo programmed cell death before they can fully mature and be released into the peripheral blood. This increased, premature cell death is a major contributor to the ineffective hematopoiesis we discussed earlier, and it directly leads to the cytopenias, the low blood counts, that characterize MDS. It's like the quality control system is working too well. In some ways, discarding too many faulty products before they even leave the factory. However, as MDS progresses, particularly towards late MDS or AML transformation, the role of apoptosis shifts dramatically. In these later stages, there's often decreased apoptosis. The abnormal, mutated cells, which should ideally be eliminated by apoptosis, somehow evade this process. This allows them to survive, accumulate, and proliferate unchecked, contributing directly to disease progression and the eventual transformation into acute myeloid leukemia. It's like the quality control system breaks down, and now all the faulty products are being released and accumulating. So, apoptosis plays a paradoxical role in MDS. In the early stages, its increase contributes to the cytopenias, making the patient sick. In the later stages, its decrease allows the malignant clone to expand, leading to more aggressive disease. This complex interplay highlights the intricate cellular mechanisms at play in MDS and why it's such a challenging disease to understand and treat. Researchers are actively exploring ways to modulate apoptosis as a therapeutic strategy in MDS. Your understanding of these cellular dynamics helps contextualize the morphological changes you observe. Next, let's look at how the WHO classifies these complex syndromes. Alright, histotechs, we've just discussed the paradoxical role of apoptosis in MDS, where cells can't quite decide if they want to live or die. Now, just as with MPNs, the World Health Organization, WHO, classification is our guiding light for understanding and categorizing myelodysplastic syndromes. This classification system is the internationally recognized standard, and it's been revised multiple times, with the most recent significant updates in 2016 and 2017, reflecting our evolving understanding of these complex disorders. It's crucial because it helps standardize diagnosis, guides prognosis, and informs treatment decisions. The WHO classification of MDS is based on a combination of factors. First, morphology is paramount. This includes the type and degree of dysplasia observed in the peripheral blood and bone marrow, as well as the percentage of blasts. Your keen eye for these cellular abnormalities is absolutely central to this classification. Second, cytogenetics plays a significant role. Specific chromosomal abnormalities are associated with certain MDS subtypes and can have prognostic implications. And third, clinical features are also taken into account, providing a comprehensive picture of the disease. Let's quickly look at some of the key categories from the 2017 WHO classification. These include refractory cytopenia with unilineage dysplasia, refractory anemia with ring sideroblasts, refractory cytopenia with multilineage dysplasia, myelodysplastic syndrome with excess blasts, MDS-EB1, MDS-EB2, myelodysplastic syndrome with isolated DEL, 5q, myelodysplastic syndrome, unclassifiable, MDSU, and childhood myelodysplastic syndrome. As you can see, it's a detailed system, and your role in meticulously identifying and documenting the morphological features is absolutely critical for placing a patient into the correct WHO category. This classification directly impacts their treatment and prognosis. Next, let's talk about the two common morphological findings that are central to all these classifications. Alright, histotex, after that whirlwind tour of the WHO classification, let's distill it down to the absolute core. Regardless of the specific subtype, there are two morphologic findings that are common to all types of myelodysplastic syndromes. These are the fundamental pillars upon which an MDS diagnosis is built, and your ability to recognize them is paramount. First, we have progressive cytopenias. This means a decrease in one or more peripheral blood cell lines. So, patients will present with anemia, low red blood cells, neutropenia, low neutrophils, or thrombocytopenia, low platelets, or a combination of these. This is the clinical manifestation of the ineffective hematopoiesis we discussed. The crucial part here is that these cytopenias occur despite a cellular bone marrow. This is the paradox of MDS. The factory might be full of workers, but they're not producing enough functional products to send out to the circulation. It's a busy, but inefficient, production line. Second, and this is where your microscopic skills are truly indispensable, we have dyspoiesis. This refers to abnormal maturation and morphology in one or more cell lines, visible in both the peripheral blood and/or the bone marrow. These are the cells that just don't look right. They might be too big, too small, have abnormal nuclear shapes, unusual granulation, or other features that deviate from normal, healthy cells. It's the visual evidence of that quality control conundrum we talked about earlier. So, the paradox is clear. You might look at a bone marrow biopsy and see enormocellular or even hypercellular marrow, packed with cells, and think, where's the problem? But then you look at the peripheral blood counts, and they're low. The disconnect is the ineffective hematopoiesis. The cells are being made, but they're faulty and don't make it to full maturity or function properly in the circulation. Your role as histotechnologists is absolutely critical in identifying these two features. You're the first line of defense, the ones who prepare the slides and often spot these subtle, yet significant, morphological abnormalities. Your observations of dysplastic changes in erythroid, myeloid, and megakaryocytic lineages are what guide the pathologist to the correct diagnosis. Without your meticulous work, these diagnoses would be far more challenging. With these core concepts in mind, let's now dive into the specific dysplastic features we look for in each cell line, starting with dyserythropoiesis. Alright, histotex, we've just covered the two core features of MDS, cytopenias and dyspoiesis. Now, let's zoom in on the specific dysplastic features we look for in MDS, starting with dyserythropoiesis. This refers to the abnormal maturation and morphology of erythroid precursors in the bone marrow and the mature red blood cells that make it into the peripheral circulation. Essentially, the red cells are getting a bit weird, and it's your job to spot these abnormalities. When you're examining the peripheral blood smear, there are several key features that screen dyserythropoiesis. First, look for oval macrocytes. These are red blood cells that are larger than normal and have an oval shape. While macroovulocytes can be seen in megaloblastic anemias and MDS, they often appear even when vitamin B12 and folate levels are normal. So, if you see these, and the B12/folate are fine, MDS should be on your radar. Next, you might encounter a dimorphic erythrocyte population. This is fascinating because you'll see two distinct populations of red cells, perhaps a mix of macrocytic cells and microcytic/hypochromic cells. It's a visual representation of the chaotic production in the bone marrow. Speaking of hypochromic microcytes, you might see these small, pale red blood cells even in the presence of adequate iron stores. This is another hallmark of ineffective erythropoiesis. The cells aren't properly hemoglobinized despite having enough raw material. Beyond these, you'll see general poikilocytosis, meaning a variety of abnormally shaped red blood cells. Keep an eye out for basophilic stippling, which are coarse, dark blue granules within the red cells, indicating abnormal ribosomal aggregation. You might also spot Howell-Jolly bodies, which are small, round, dark blue inclusions representing nuclear remnants that should have been extruded during maturation. And finally, siderocytes, also known as Pappenheimer bodies, are red cells containing non-heme iron granules, often visible with a Prussian blue stain. Each of these morphological oddities tells a story about the dysfunctional erythropoiesis occurring in the bone marrow. Your meticulous observation and identification of these features are crucial for the diagnosis of MDS. It's like being a forensic artist, sketching the abnormalities you see. Next, we'll move into the bone marrow to see the dysplastic erythroid precursors themselves. Alright, histotechs, we've seen the red cell oddities in the peripheral blood. Now, let's go to the heart of the problem, the bone marrow, where the erythroid precursors are supposed to be maturing. In MDS, dyserythropoiesis in the bone marrow is characterized by a fascinating array of abnormalities in these developing red blood cells. This is where you'll see the most dramatic evidence of ineffective hematopoiesis. One of the most striking features is the presence of multinucleated erythrocyte precursors. Instead of a single, neat nucleus, you'll find erythroid cells with 2, 3, or even more nuclei. It's like the cell division process has gone a bit haywire, and the nuclei aren't separating properly. Then there are the abnormal nuclear shapes. The normally round nucleus of an erythroid precursor might appear irregular, with budding, lobulation, or even fragmentation. These bizarre shapes are a clear sign of dysplastic maturation. And sometimes, you'll even spot nuclear bridging, thin strands of chromatin connecting two nuclei or nuclear lobes. This is a particularly strong indicator of dyserythropoiesis. Beyond the nucleus, the cytoplasm can also show abnormalities. You might observe uneven cytoplasmic staining, reflecting discrepancies in hemoglobinization or basophilia. Some areas might be well hemoglobinized, while others are pale, or you might see patchy basophilia. This indicates a problem with the coordinated development of the cell. Vacuolization, the presence of small, clear spaces or vacuoles in the cytoplasm, can also be seen in erythroid precursors. This is another nonspecific sign of cellular stress and abnormal development. And finally, you might encounter megablastoid features. This refers to large erythroid precursors that exhibit asynchronous maturation, meaning the nucleus appears immature while the cytoplasm is more mature, or vice versa. This is a classic sign of nuclear cytoplasmic asynchrony. What's crucial here is that these megablastoid features occur despite normal vitamin B12 and folate levels, differentiating them from true megaloblastic anemias. Your meticulous observation of these nuclear and cytoplasmic abnormalities in erythroid precursors is absolutely essential for diagnosing dyserythropoiesis in MDS. It's a direct window into the dysfunctional red cell production line. Next, let's specifically focus on those bizarre nuclear abnormalities. Alright, histotechs, we've just explored the general dyserythropoiesis in the bone marrow. Now, let's get even more granular and focus specifically on the nuclear abnormalities in erythroid precursors that are characteristic of dyserythropoiesis in MDS. These are some of the most striking and diagnostically significant features you'll encounter, and they really highlight the chaos within the nucleus of these developing red cells. First up, multinucleation. Instead of the typical single nucleus, you'll see erythroid precursors with 2, 3, or even more nuclei. This is a clear sign of abnormal cell division or nuclear segregation, where the cell attempts to divide but the nuclei don't separate properly. It's like a cellular identity crisis. Then we have nuclear budding. Imagine the nucleus trying to pinch off a piece of itself, forming small, irregular protrusions or outgrowths. These buds can sometimes detach and remain in the cytoplasm as Howell-Jolly bodies, which we discussed earlier. It's a sign of nuclear instability. Nuclear lobulation is another common finding. Instead of a smooth, round nucleus, you'll see indentations or divisions, giving the nucleus a lobed appearance. This is similar to what we see in granulocytes, but it's abnormal for erythroid precursors. Nuclear fragmentation refers to the breakup of the nucleus into smaller pieces within the cytoplasm. This is a more severe form of nuclear disorganization and indicates significant cellular distress. And a particularly classic and diagnostically important feature is nuclear bridging. This is where you see thin strands of chromatin connecting two nuclei, or even two distinct lobes of a single nucleus. It's a very specific and strong indicator of dyserythropoiesis, suggesting problems with cytokinesis or nuclear division. When you see nuclear bridging, you should immediately think MDS. Finally, we have irregular nuclear shapes, which is a general term for any deviation from the normal round or oval nucleus. This can include bizarre, angular, or otherwise distorted nuclear contours. All these abnormalities collectively point to a fundamental problem with the genetic machinery and division processes within the erythroid precursors. Your ability to meticulously identify and document these nuclear nightmares, the buds, bridges, and fragments, is absolutely crucial for the accurate diagnosis of dyserythropoiesis in MDS. These are not subtle findings, and they are direct evidence of the ineffective and dysplastic hematopoiesis occurring in the bone marrow. Next, let's look at the cytoplasmic side of things. Alright, histotechs, we've dissected the nuclear abnormalities in dyserythropoiesis. Now, let's turn our attention to the cytoplasmic abnormalities in erythroid precursors. The cytoplasm, too, can tell us a great deal about the dysfunctional maturation occurring in MDS. One common finding is uneven cytoplasmic staining. Instead of a smooth, uniform color, you might see patchy or irregular hemoglobinization or basophilia. This indicates a problem with the coordinated synthesis and distribution of hemoglobin or other cytoplasmic components. It's like the cell is trying to paint itself, but it's doing a very sloppy job. Vacuolization, the presence of clear spaces or vacuoles within the cytoplasm, is another feature you might observe. These vacuoles can vary in size and number and are generally a nonspecific sign of cellular stress or metabolic disturbance. They're like little bubbles forming in the cytoplasm, indicating something isn't quite right. A particularly important concept, and one that often goes hand in hand with megablastoid features, is nuclear cytoplasmic asynchrony. This is a discrepancy between the maturation rate of the nucleus and the cytoplasm. In MDS, you might see a nucleus that appears immature, large, with open chromatin, while the cytoplasm is already showing signs of maturity, such as hemoglobinization. This asynchronous maturation is a hallmark of dyserythropoiesis and reflects a fundamental defect in the coordinated development of the cell. And finally, a very specific and diagnostically important cytoplasmic abnormality, though it requires a special stain, is the presence of ring sideroblasts. These are erythroid precursors that, when stained with Prussian blue, show 5 or more iron granules encircling at least 1/3 of the nucleus. Your careful observation of these cytoplasmic features, especially nuclear cytoplasmic asynchrony and the potential for ring sideroblasts, provides crucial evidence for dyserythropoiesis. It's all about putting together these subtle clues to build a comprehensive diagnostic picture. Next, we'll talk more about the significance of ring sideroblasts. Alright, histotechs, we've just discussed the various cytoplasmic abnormalities. Now, let's dedicate a whole slide to one of the most distinctive and diagnostically important features of dyserythropoiesis, the ring sideroblast. This is a cellular anomaly that, once you see it, you won't forget it, and it carries significant weight in the diagnosis of certain MDS subtypes. So, what exactly is a ring sideroblast? It's an erythroid precursor, or normoblast, in the bone marrow that contains 5 or more iron granules that encircle at least 1/3 of the nucleus. The key here is the ring formation. These aren't just scattered iron granules, they form a distinct necklace around the nucleus. Now, you won't see these on a routine Röntgen stain. To visualize these iron granules, you absolutely need a special iron stain, specifically the Prussian blue stain. This stain reacts with non-heme iron, turning it blue, making these granules clearly visible. What's the pathogenesis behind these ring sideroblasts? They represent a defect in heme synthesis. This leads to the accumulation of non-heme iron within the mitochondria, which then cluster around the nucleus. It's like the cell is trying to build a car, but it can't properly incorporate the engine parts. The diagnostic significance of ring sideroblasts is profound. Their presence is a key diagnostic criterion for certain MDS subtypes, most notably refractory anemia with ring sideroblasts, RARS. So, identifying these cells directly impacts the patient's diagnosis. It's also important to differentiate ring sideroblasts from normal sideroblasts. Normal sideroblasts are erythroid precursors that contain a few, scattered iron granules in their cytoplasm. The distinction lies in the number of granules and, crucially, their paranuclear distribution, that characteristic ring. Your ability to make this distinction accurately, using the Prussian blue stain, is a testament to your specialized skills as histotechs. Next, let's briefly touch upon megablastoid development in the context of MDS. Alright, histotechs, we've just covered the fascinating ring sideroblasts. Now, let's wrap up our discussion on dyserythropoiesis with a look at megablastoid development. This is a fascinating feature because it can mimic something else entirely, but with a crucial twist that points us directly back to MDS. Megablastoid features refer to the presence of large erythroid precursors in the bone marrow that exhibit nuclear cytoplasmic asynchrony. Remember we talked about this earlier? It's where the nucleus appears immature, it's large, with open, delicate chromatin, while the cytoplasm is more mature, often showing signs of hemoglobinization. It's like the nucleus is still in kindergarten while the cytoplasm has already graduated from college. This asynchronous maturation is a clear sign of disordered development. Now, here's the key differentiator and why it's so important. In MDS, these megablastoid features occur despite normal vitamin B12 and folate levels. This is critical because the classic cause of megaloblastic features and nuclear cytoplasmic asynchrony is a deficiency in vitamin B12 or folate, which are essential for DNA synthesis. In those cases, the nucleus can't mature properly because DNA replication is impaired. So, the contrast with true megaloblastic anemia is vital. If a patient has megaloblastic features and low B12 or folate, you treat the deficiency. But if they have these features and their B12 and folate levels are perfectly normal, then you're looking at something else, and MDS is a prime suspect. In MDS, the megablastoid features reflect a primary defect in DNA synthesis or maturation within the dysplastic clone itself, not a nutritional deficiency. It's an intrinsic problem with the cell's machinery, not a lack of raw materials. Your role in recognizing these megablastoid features and understanding their context within normal B12 and folate levels is crucial for guiding the diagnostic process. It helps differentiate MDS from easily treatable nutritional deficiencies. With that, we've thoroughly covered dyserythropoiesis. Next, let's move on to the abnormalities we see in the myeloid lineage, dysmyelopoiesis. Alright, histotechs, we've thoroughly explored the weird and wonderful world of dyserythropoiesis. Now, let's shift our focus to the myeloid lineage and delve into dysmyelopoiesis. This refers to the abnormal maturation and morphology of granulocytic precursors in the bone marrow and the mature granulocytes that make it into the peripheral blood. Essentially, our neutrophils, eosinophils, and basophils are not developing as they should, and it's your job to spot these deviations. When you're examining the peripheral blood smear, there are several key features that point to dysmyelopoiesis. First, look for abnormal granulation. Neutrophils, which should be packed with fine, pinkish-purple granules, might show hypergranulation or even complete agranulation. These cells can appear pale or empty. This defect in granule formation impacts the cell's ability to fight infection. Next, pay close attention to abnormal nuclear shapes. A classic finding is hyposegmentation, where the neutrophil nucleus has fewer than the normal 2 to 5 lobes, often appearing bilobed or even unsegmented. This is known as the pseudopelger-Hued anomaly, mimicking a benign inherited condition, but, in MDS, it's a sign of dysplasia. You might also see hypersegmentation in some neutrophils, or even bizarre ring-shaped nuclei, where the nucleus forms a complete circle. These are all clear signs of abnormal nuclear development. Another feature is persistent basophilic cytoplasm. This indicates nuclear cytoplasmic asynchrony, where the cytoplasm retains an immature, basophilic appearance even though the nucleus might appear more mature. Your meticulous observation of these abnormal granulation patterns, bizarre nuclear shapes, and asynchronous maturation in granulocytes is absolutely essential for diagnosing dysmyelopoiesis in MDS. It's like being a detective, looking for all the subtle clues that something is wrong with the cellular machinery. Next, let's delve deeper into nuclear cytoplasmic asynchrony. Alright, histotechs, let's hone in on a concept we've touched upon in erythropoiesis and is equally important in dysmyelopoiesis, nuclear cytoplasmic asynchrony. This is a subtle but critical sign of dysplasia, and it refers to a discrepancy in the maturation rates of the nucleus and cytoplasm within a developing granulocyte. Normally, these two processes happen in a coordinated fashion, but in MDS, this coordination is lost. The most common manifestation you'll see is a nucleus that appears immature. It might be larger than expected, with less condensed, more open chromatin, while the cytoplasm appears relatively more mature, having developed granules and lost some of its deep basophilia. It's like the nucleus is still in its teenage years, while the cytoplasm has already hit adulthood. A key visual indicator of this asynchrony is persistent basophilic cytoplasm. Even in granulocytes that appear morphologically mature, their cytoplasm might retain an abnormal degree of blueness, indicating an immature ribosomal content, despite the nucleus having undergone segmentation. The significance of nuclear cytoplasmic asynchrony is profound. It reflects a fundamental defect in the coordinated maturation process of granulocytes. This isn't just an aesthetic problem, it has functional consequences. Even if these neutrophils make it into the peripheral blood, they are often functionally impaired, contributing to the patient's susceptibility to infections. Your ability to recognize this asynchronous tango between the nucleus and cytoplasm is a hallmark of your expertise as a histotech. Next, let's talk more about those abnormal granulation patterns. Alright, histotechs, let's focus on another critical feature of dysmyelopoiesis, abnormal granulation in myeloid cells. This is something you'll see frequently, and it has significant implications for the function of these cells. First, we have hypogranulation. This means there's a decreased number of specific, or secondary, granules in neutrophils, eosinophils, or basophils. In neutrophils, which should be packed with those fine, pinkish-purple granules, hypogranulation makes their cytoplasm appear pale or empty. It's like the cell's internal pantry is running low on supplies. Even more striking is agranulation. This is the complete absence of granules, particularly in neutrophils. An agranular neutrophil can be quite a challenge to identify correctly because it might lack the characteristic features that distinguish it from other cell types. In fact, granular neutrophils can sometimes be misidentified as monocytes or even blasts, which can lead to serious diagnostic errors. The significance of abnormal granulation goes beyond just appearance. It directly impacts the cellular function, particularly phagocytosis and bacterial killing in neutrophils. These granules contain crucial enzymes and antimicrobial proteins essential for destroying ingested pathogens. If the granules are missing or deficient, the neutrophil's ability to fight infection is severely compromised. Your meticulous observation of these granulation patterns is crucial. Next, let's talk about those bizarre nuclear shapes that can also appear in myeloid cells. Alright, histotechs, we've talked about granulation, now let's delve into another fascinating aspect of dysmelopoiesis, abnormal nuclear shapes in myeloid cells. The nucleus of a neutrophil, which should normally be segmented into 2 to 5 lobes, can take on some rather bizarre forms in MDS, and recognizing these is crucial. Perhaps the most classic and diagnostically significant is hyposegmentation, often referred to as the pseudopelger anomaly. In these neutrophils, the nucleus has fewer than the normal number of lobes, often appearing bilobed, like pince-nez glasses, or even completely unsegmented, resembling a band form. It's important to distinguish this from the true Pelger-Hute anomaly, which is a benign, inherited condition. In MDS, it's a clear sign of dysplasia, indicating abnormal nuclear maturation. Another striking abnormality is the presence of ring-shaped nuclei. This is where the nucleus forms a complete circle or a donut shape. It's a relatively rare but very distinctive dysplastic feature. While less common in MDS than in megaloblastic anemias, you might also occasionally see hypersegmentation. These are neutrophils with more than 5 nuclear lobes. The significance of these abnormal nuclear shapes is that they reflect abnormal nuclear maturation. The processes that govern nuclear segmentation and chromatin condensation are disrupted, which can impact neutrophil function. Your ability to accurately identify these nuclear oddities, the pseudopelger cells, ring-shaped nuclei, and any unusual segmentation, is a key skill in diagnosing dysmelopoiesis. Next, let's talk about a very specific finding in the bone marrow, abnormal localization of immature precursors. Alright, histotechs, let's talk about a very specific and diagnostically important finding in the bone marrow that points to dysmelopoiesis and MDS, abnormal localization of immature precursors, or ALIP. This is a feature you'll primarily assess on a bone marrow biopsy, and it's a powerful indicator of disease. A LIP is defined as clusters of 3 or more immature myeloid precursors, specifically myeloblasts and promyelocytes, located centrally in the bone marrow biopsy, away from the endosteal surface. Now, why is this abnormal? Because normally, myeloblasts and promyelocytes, being the youngest and most primitive myeloid cells, tend to reside along the endosteal surface, which is the inner lining of the bone. In MDS, however, these immature cells decide to set up shop in the middle of the marrow space, forming distinct clusters. This abnormal localization is not just a random occurrence, it's a direct reflection of the disordered hematopoiesis in MDS. The diagnostic significance of ALIP is considerable. It is considered a characteristic finding in bone marrow biopsy specimens from patients with MDS, particularly those subtypes that have a higher risk of transforming into acute myeloid leukemia. So, when you see these central clusters of immature myeloid cells, it's a strong signal that you're dealing with MDS. Furthermore, the presence of ALIP is also considered a prognostic indicator. It is generally associated with a poorer prognosis in MDS, suggesting a more aggressive disease course and a higher likelihood of progression to AML. This makes its identification crucial for risk stratification and guiding treatment decisions. Your meticulous examination of bone marrow biopsies for these subtle architectural changes, specifically the presence and location of immature myeloid clusters, is incredibly important. Next, let's move on to the abnormalities we see in the megakaryocytic lineage, dysmegakaryopoiesis. Alright, histotechs, we've covered the red cells and the white cells. Now, let's complete our tour of dysplasia in MDS by looking at the megakaryocytic lineage, dysmegakaryopoiesis. This refers to the abnormal maturation and morphology of megakaryocytes in the bone marrow and their progeny, the platelets, in the peripheral blood. Essentially, the platelets are developing some serious personality quirks, and it's your job to spot them. When you're examining the peripheral blood smear, there are several key features that point to dysmegakaryopoiesis. First, look for giant platelets. These are platelets that are abnormally large, sometimes even larger than red blood cells. They are a direct result of abnormal megakaryocyte maturation in the bone marrow, where the megakaryocytes might undergo abnormal fragmentation or incomplete maturation. Next, similar to granulocytes, platelets can also exhibit abnormal granulation. You might see hypogranulation, decreased granules, or even aggranulation, absence of granules, in platelets. These granules are crucial for platelet function, containing factors necessary for coagulation and aggregation. So, platelets with abnormal granulation are often functionally impaired, contributing to the bleeding tendencies seen in some MDS patients. A particularly striking and diagnostically significant finding is the presence of circulating micromegakaryocytes. These are small, immature megakaryocytes or megakaryoblasts that are released into the peripheral blood. Normally, megakaryocytes are large, multinucleated cells confined to the bone marrow. Their appearance in the peripheral blood is a clear sign of severely dysplastic and ineffective megakaryopoiesis. When you see these, it's a strong indicator of MDS. Finally, and often as a consequence of this ineffective production, patients with dysmegakaryopoiesis will frequently present with thrombocytopenia, a decreased platelet count. Despite the bone marrow trying to produce platelets, the production is often ineffective, leading to low numbers of functional platelets in the circulation. Your meticulous observation of these platelet features, their size, granulation, and the presence of circulating micromegakaryocytes is absolutely essential for diagnosing dysmegakaryopoiesis in MDS. It's another piece of the puzzle that helps paint a comprehensive picture of the underlying bone marrow disorder. Next, let's take a closer look at those fascinating circulating micromegakaryocytes. Alright, histotechs, let's shine a spotlight on a particularly interesting and diagnostically significant feature of dysmegakaryopoiesis, circulating micromegakaryocytes. These are truly unique cells that, when you spot them, should immediately raise your suspicion for MDS. By definition, circulating micromegakaryocytes are small, immature megakaryocytes or megakaryoblasts found in the peripheral blood. Now, this is highly abnormal. Normal, mature megakaryocytes are the largest cells in the bone marrow, and they stay there, releasing platelets into the circulation. Their appearance in the peripheral blood signifies a severe disruption in megakaryopoiesis. In terms of morphology, they are typically smaller than normal megakaryocytes, but still larger than most other peripheral blood cells. They often have a single, round, or slightly lobulated nucleus and scant, often hypogranulated cytoplasm. Sometimes, they can be confused with blasts due to their immature appearance, but careful attention to the nuclear chromatin pattern, the presence of any cytoplasmic granulation, even if abnormal, and the overall context can help differentiate them. The significance of circulating micromegakaryocytes is profound. Their presence is a clear indicator of severely dysplastic and ineffective megakaryopoiesis in the bone marrow. It tells us that the megakaryocyte production line is so dysfunctional that it's releasing these immature, abnormal forms into the circulation. This is a strong morphological marker for MDS and can also be seen in some myeloproliferative neoplasms, particularly primary myelofibrosis. Differentiation from blasts is crucial. While both are immature cells, blasts typically have a higher nuclear to cytoplasmic ratio, more prominent nucleoli, and lack the subtle features of megakaryocytic differentiation. Your experience and keen eye are essential here to avoid misclassification, which can have significant implications for diagnosis and treatment. So, when you're scanning a peripheral blood smear and you come across one of these tiny giants, remember its significance. It's a powerful clue that the bone marrow is struggling to produce healthy platelets and is a strong indicator of an underlying myelodysplastic syndrome. Next, let's head into the bone marrow to see the dysplastic megakaryocytes themselves. Alright, histotechs, we've seen the abnormal platelets and micromegakaryocytes in the peripheral blood. Now, let's go to the source and examine dysmegakaryopoiesis in the bone marrow. This is where the megakaryocytes themselves exhibit a wide array of morphological abnormalities, reflecting the underlying dysplastic process. One striking feature you might encounter is large mononuclear megakaryocytes. Normally, mature megakaryocytes are large cells with highly lobulated nuclei. In MDS, you might see abnormally large megakaryocytes that, instead of having a complex, lobulated nucleus, have a single, often round or oval nucleus. On the other end of the spectrum, you'll also find micromegakaryocytes or micromegakaryocytes. These are abnormally small megakaryocytes or their precursors. Then there are the abnormal nuclear shapes. Instead of the characteristic multilobulated nucleus, you might see hypolobulated nuclei or, conversely, hyperlobulated nuclei. A particularly distinctive feature is multiple separated nuclei, where the nucleus appears to have fragmented into several distinct, unconnected pieces within the cytoplasm. You might also observe an uneven number of nuclei. Finally, similar to other myeloid cells, megakaryocytes can also exhibit abnormal granulation. You might see hypergranulation or agranulation in their cytoplasm. Your meticulous observation of these diverse morphological abnormalities in megakaryocytes, their size, nuclear configuration, and granulation, is absolutely essential for diagnosing dysmegakaryopoiesis in MDS. It's a direct window into the dysfunctional platelet production line. Next, let's specifically compare the abnormal megakaryocyte morphology to what we'd expect to see normally. Alright, histotechs, let's consolidate our understanding of dysmegakaryopoiesis by doing a direct comparison. What does a normal megakaryocyte look like, and how do the dysplastic megakaryocytes we see in MDS deviate from that norm? This side-by-side comparison is crucial for solidifying your diagnostic eye. A normal megakaryocyte is truly a magnificent cell. It's the largest cell in the bone marrow, with abundant, granular cytoplasm, and its most striking feature is its highly lobulated nucleus, often containing 8 to 16 lobes. This complex nuclear structure is essential for its function, as it's involved in the process of platelet formation. Think of it as a beautifully organized, multi-chambered control center. Now, let's contrast that with the dysplastic megakaryocyte features we encounter in MDS. First, we have micromegakaryocytes. These are abnormally small megakaryocytes, a stark contrast to the large size of normal megakaryocytes. Their small size and often immature appearance are clear signs of abnormal development. Then there are large mononuclear megakaryocytes. These cells are large, like normal megakaryocytes, but instead of that beautiful, highly lobulated nucleus, they possess a single, often round or oval, unlobulated nucleus. It's like the control center is there, but it's missing all its internal divisions. We also see abnormalities in lobulation. Hypolobulated nuclei have fewer than the normal number of lobes, sometimes appearing bilobed or even unsegmented. Conversely, hyperlobulated nuclei exhibit excessive, often bizarre, and irregular lobulation, which can be quite chaotic in appearance. Both extremes indicate a problem with nuclear maturation. And finally, a very distinctive feature is separated nuclei. Instead of a single, albeit lobulated, nucleus, the nucleus appears fragmented into multiple distinct, unconnected pieces within the cytoplasm. This is a clear sign of severe nuclear disorganization and a strong indicator of dysmegakaryopoiesis. Your ability to recognize these diverse morphological changes, from micromegakaryocytes to large mononuclear forms, and the various nuclear abnormalities, is absolutely essential for accurately diagnosing dysmegakaryopoiesis. It's about understanding the spectrum of what can go wrong in the megakaryocyte lineage. With that, we've covered the three main lineages of dysplasia in MDS. Next, let's briefly touch upon how myeloid hematopoietic growth factors can alter morphology, which is important to consider when interpreting slides. Alright, histotechs, for our penultimate slide, let's discuss something incredibly important for your diagnostic practice: the morphologic changes that can occur after the administration of myeloid hematopoietic growth factors. This is a therapeutic curveball that can significantly alter what you see on a peripheral blood smear and can sometimes mimic serious hematologic conditions. Myeloid growth factors, such as granulocyte colony stimulating factor, GCSF, and granulocyte/macrophage colony stimulating factor, GM-CSF, are commonly used in clinical practice. Their therapeutic use is to stimulate the production of myeloid cells, particularly neutrophils. This is often done to combat neutropenia, low neutrophil counts, in patients undergoing chemotherapy, or to mobilize stem cells for transplantation. They're essentially giving the bone marrow a powerful boost to produce more white blood cells. However, this therapeutic boost comes with characteristic morphologic changes that you need to be aware of when interpreting peripheral blood smears. First, you'll see transient leukocytosis, an increase in white blood cells, which is the intended effect. But along with that, you'll often observe immature granulocytic cells, indicating a left shift, with myelocytes, metamyelocytes, and even promyelocytes appearing in the peripheral blood. It's like the factory is working so fast it's pushing out cells before they're fully mature. Neutrophils themselves can show some interesting changes. You might see vacuolated and giant neutrophils, meaning they have clear spaces in their cytoplasm and are abnormally large. Toxic granulation, which are coarse, dark granules in the neutrophils, and dull bodies, which are pale blue inclusions in the neutrophil cytoplasm, are also common. These are typically associated with severe infection, but here they are induced by the growth factors. You might also see some hypogranulation. And critically, you might even spot nucleated red blood cells, NRBCs, and, in some cases, up to 5% blasts in the peripheral blood. This is where it gets tricky. The clinical significance of these changes is profound. These therapy-induced morphological alterations can mimic severe infection, acute myeloid leukemia, or myelodysplastic/myeloproliferative neoplasms. Imagine seeing a patient with leukocytosis, a left shift, toxic granulation, and even some blasts. Without knowing they're on GCSF, you might jump to a very different, and incorrect, diagnosis. Therefore, it is absolutely crucial to always consider the patient's clinical history and current medications when interpreting these smears. Your role is not just to identify the cells, but to interpret them in context. It's a powerful reminder that the microscope never lies, but sometimes it needs a little help from the patient's chart to tell the full truth. Finally, let's wrap things up with a conclusion. Alright, histotechs, we've reached the end of our journey through the complex and often challenging world of myeloproliferative neoplasms and myelodysplastic syndromes. I hope you found this deep dive as fascinating as I have, and that you now feel better equipped to tackle these diagnoses in your daily practice. Let's quickly recap the big takeaways. We learned that MPNs are clonal disorders characterized by excessive proliferation of one or more myeloid cell lines. We explored the distinct personalities of CML, with its famous Philadelphia chromosome and granulocytic excess, PV, the red cell rush driven by JAK2 mutations, ET, the platelet party that can lead to paradoxical clotting and bleeding, and PMF, the scarring of the bone marrow that gives us those classic teardrop cells and extramedullary hematopoiesis. Then, we delved into MDS, the clonal disorders of ineffective hematopoiesis, cytopenias, and dysplasia. Here, the problem isn't just too many cells, but cells that are fundamentally flawed in their maturation. We meticulously examined the abnormal maturation in erythroid, myeloid, and megakaryocytic lineages, looking at everything from multinucleated red cell precursors and ring sideroblasts to hypogranulated neutrophils and circulating micromegakaryocytes. But beyond the textbook definitions and the intricate cellular details, there's one message I want you to take home above all else: your role as histotechnologists is absolutely critical. You are the unsung heroes behind every accurate diagnosis. Your meticulous preparation of peripheral blood smears and bone marrow biopsies and aspirates is the foundation upon which everything else is built. Without a well-prepared slide, even the most experienced pathologist is flying blind. Furthermore, your keen observation and accurate identification of subtle morphological abnormalities are paramount. These aren't always obvious changes. Sometimes, it's a slight shift in granulation, a peculiar nuclear shape, or a cell in an unexpected location that provides the crucial clue. Your eyes are trained instruments, and your attention to detail can literally change a patient's life. And finally, remember the importance of understanding the clinical context and the impact of therapeutic interventions. As we saw with myeloid growth factors, treatments can alter morphology, and knowing the patient's history is essential for correct interpretation. You are not just technicians, you are vital members of the diagnostic team, contributing your specialized knowledge to the overall patient picture. In conclusion, your work is fundamental to accurate diagnosis, prognosis, and guiding patient treatment in these complex hematologic disorders. You are the guardians of the microscopic world, and your expertise directly impacts our patients' future. Keep learning, keep observing, and keep being awesome histotechs. Thank you.